Resources and Services Administration Technical Assistance. Today's session, we're focusing on something that we heard from all of you on previous webinars, is something that you wanted to hear about. So strategies for providing health care for frequent users in rural communities. We are providing this webinar as part of our HRSA Technical Assistance Program. CSH is a national nonprofit, and our mission is to advance housing solutions that improve the lives of vulnerable people, maximize public resources, and build strong, healthy communities. We are a technical assistance provider for HRSA, and we are also a technical assistance provider for HUD. As part of our HRSA technical assistance, our focus is on building relationships and building collaborations between housing providers and healthcare providers for those most vulnerable people in our communities who are frequently using the emergency and crisis care systems. One of our major partners under the technical assistance work that we do is the National Healthcare for the Homeless, and then, of course, HRSA. We provide this webinar series, direct technical assistance, and do peer-to-peer networks and on in-person trainings. I'm very excited to introduce our panelists today for this topic, focusing on delivering healthcare in rural communities. We really have a diverse group and representing different communities. First off, we have Zachary Brown, and Zachary is the Executive Director of the West Virginia Coalition to End Homelessness. And he's going to talk about how they've been working with the healthcare providers in their rural communities, and also about some of their ways that they are providing services to homeless and lessons that can be learned from that. Next, we have Lindsay Cassell, who is the Housing First Program Manager with Pathways Vermont, and they cover the entire state of Vermont and provide both housing and behavioral health services. And Terry Kluch is the Division Administrator for Dental with the Family Health Clinic, which is part of the Marshville Clinic in Wisconsin. And so we're very pleased to be able to have Terry talk about how they're providing dental services, which is often very difficult to find, not only in rural communities, but in urban communities for the hard-to-serve populations. I'm Jane Bilger, and you already heard from Emma Chappelle, our Associate Program Manager. So let me just set the stage here a little bit. Our objectives is to help folks have an increased understanding of the health and housing needs of the high utilizers in our rural communities. We're going to have our panelists talk about how they are connecting health and housing, and so you'll focus on those strategies, and then you're going to hear from as I said, the examples in the field. We will also have a dialogue. So each of the partners will talk about their programs, and then we're going to introduce some questions and have dialogue among the panelists. And then, of course, we try to leave time for questions and answers from all of you listening. And my colleague, Kim Keaton, is going to manage the Q&A towards the end of our session. So please type in your questions in the chat box as we go along. So let me just set the stage a little bit. And some of this information I've taken from our colleague, National Healthcare for the Homeless. They put in their quarterly magazine, In Focus, in June of 2013, they did a literature review on rural homelessness. So some of the points here are taken from that. So while homelessness is often thought of as an urban phenomenon, there are many conditions in rural communities that foster homelessness, but it also keeps it very hidden. These conditions contribute to homelessness, and they've been occurring for over a long period of time, over decades. First is significant is an outmigration of jobs and populations. This is, we're hearing a lot about loss of manufacturing jobs, loss of family farms. So it's increasing population outmigration and also contributing to an increased level of poverty in rural communities. Demographics are changing because as the jobs go, many times young people are moving to different areas in chasing jobs. So we have young people moving out, older people with less opportunities are staying, and so there's a rising age among folks in the rural communities. We also find that there's limited investment in the infrastructure, and that can be seen in deterioration of some of the housing stock, less investment in newer affordable housing, and also less investment in facilities for providing services. Clearly, the travel distances and transportation make it difficult to provide services and also contribute to the invisibility of the folks facing homelessness. You can't see them as much when it's spread out over large areas. Two things I also want to mention is the culture. There's very much, and this is maybe a gross exaggeration or is that the culture. There's also difficulty in the culture of accepting help and feeling as if folks need to take on their problems and handle them themselves. Or maybe there's a denial of the problem. And often what is found in both rural and urban communities, the crisis care in the hospitals or the criminal justice systems, the police departments, are the ones that are first getting involved with homeless populations and other frequent users in the community. And last, I want to just point out, and there are a lot of other sessions going on at in different venues talking about, the increase in the opioid and other drug epidemic that's plaguing rural communities, and that also is contributing to certainly healthcare crisis and also homelessness. And some of these points were also covered, I just covered, but, we find that homelessness is invisible in rural communities because what homelessness looks like is often it's folks that are maybe living in vehicles or doubling up or couch surfing, and so that it's not as much prevalent, it's not as prevalent on the street homelessness. Or it could be folks living in unstable or poor housing conditions. There may be a roof over the head, but it's really unstable conditions. Clearly, there's fewer resources and limited access to shelters and affordable housing, which is all contributing to the housing conditions that, as we know, as social determinants of health, housing is health care. We know that when housing is unstable, there's really not the environment for folks to address their health conditions. So we really want to focus on how we can make those linkages between both housing and health care. Some of the promising practices you're going to hear about today is where there is care coordination across the primary, behavioral, and dental health care, how rural communities are using both technology and transportation to increase access. And then, of course, our major focus is how do you do outreach, how do you bring people in, and how do you build partnerships. With that, I am going to turn it over to the first of our panelists. We have Lindsay Cassell, who's with Pathways Vermont. So Lindsay, I will move the slides for you, so just tell me when you're ready.
All right, thank you very much. Hi, everyone. My name is Lindsay Cassell, and as Jane said, I work as the program manager for the Housing First program here at Pathways Vermont. Pathways is a local nonprofit organization that provides increased access to services in the areas of choice, connection, and home. And we currently have 5 programs that support these efforts. Today, I'm going to spend the bulk of my time talking about our most senior program and also our largest program, the Housing First program. Many of you are likely familiar with Housing First as it's gained popularity over the past few years on a national level. Housing First is defined as a program that provides immediate access to permanent supportive housing and support services for people who are experiencing chronic homelessness and who also experience significant mental health challenges such that are a barrier to their independent living. Chronic homelessness is defined as long-term homelessness, so folks who either have been homeless for a year in this current episode or who have had 4 or more episodes of homelessness in the last 3 years. And by permanent, I mean folks are signing independent leases with the option to renew, and they're living as members of their community with indefinite timelines. Housing First services are provided to individuals as long as they'd like them, and there are no parameters around how long someone can stay in our program. And then immediate is, of course, the most shocking one. This both means as quickly as possible, so housing as the first, though not the only step in providing services and support to individuals and families. But immediate also means differently than we have traditionally approached homelessness in the United States. So by immediate, I mean without preconditions, without asking that people demonstrate a readiness to housing, whether that be through a period of sobriety or mental health service compliance or through employment. We provide housing to any person who's experiencing chronic homelessness without asking anything more than they are as a person experiencing chronic homelessness. This is a radical model that was developed in the 1990s in a very urban environment. Our founder, Dr. Samson Barris, was working in New York City and was finding that people were caught in what we call the institutional circuit. So people experiencing homelessness were also the same people that they were seeing as high utilizers of other expensive services, the folks that were in the hospitals, in jails, and in the expensive ER and motel settings. As he witnessed this revolving door and that people were unable to escape it, they spent time asking people, what do you want? And very not surprisingly, people who were experiencing homelessness universally said that the thing that they wanted most was housing. And so this idea got started that we should listen to people when they say what they want and provide that. And a lot of research went into proving that this was not only a model that made some logical sense, but was also a very effective model. In 2007, Housing First was entered into the National Evidence-Based Practice Registry, and it's gained a lot of popularity since then. In 2009, Housing First came to Vermont, and it came to Vermont as a demonstration project. This was a model that had been widely successful in a number of very urban environments, and so we came to Vermont to see if this was something that could be adapted to a rural state, and that was met with a variety of challenges. Just to give you a quick information about Vermont, Vermont is a very small state. Our total population is just over 600,000. Our population density, as you can see, is very, very small. Actually, in 1989, there were more cows than people in the state of Vermont. Since then, we now have more people than cows. We still have the largest population of cows for any state. And Vermont is challenging in terms of its topography. It's a state that is twice as long as it is wide, but because it's very mountainous, it takes the same amount of time to travel across the state as it does up and down the state. To give you a little bit of context on the issue of homelessness in the state of Vermont, these are some numbers. As Jane talked about, these numbers are imperfect because it's hard to measure homelessness in a rural environment. These numbers measure people that are experiencing the HUD definition of homelessness, which does not include couch surfing or the folks that we can't find, the folks that, people aren't aware of because maybe they're out sleeping in some very rural field or they're in a rundown building that isn't up to code, but, they're squatting there. That said, these numbers are still relatively large given our state population. And the resources that we have had prior to Housing First in the state are not sufficient to meet the needs of our community. We have shelter beds only for about a third of the population that experiences homelessness annually, and that's a significant issue. Also, the resources that I list here are all temporary solutions to homelessness, stopgaps, and they certainly leave a lot of people behind. And this is the kind of the frame by which Housing First has become adopted in Vermont. To give you a little bit of a sense of, if we can go back one slide, how we're currently providing services here in the state. Currently, we're in 6 communities, so we're not truly statewide, although we do have services both in the very most northern part of our state and the very most southern part of our state. So that means our staff has a lot of travel time. We've recently adapted to local teams, so we are trying to keep teams within our small rural communities, and that's really important in a rural place because, as I'm sure many of you know, the types of services and supports that are different vary very widely from community to community. So having people who are rooted in those communities is incredibly important. And we have teams of folks that are providing support to the folks that we're working with. As I said, Housing First is really, housing is the first step. And then there's a robust behavioral health service team that continues to provide ongoing support. And that's what supports people to stay in their housing and to meet other life goals. And those are some of the specialties that we provide services for. Next slide, please. Thank you. Quickly talk a little bit about the impact of having these services. Not surprisingly, or maybe it's surprisingly to some of you, but it is actually less expensive to support people with both housing subsidies, so that housing is affordable, as well as services, than it is to do nothing at all. Because when people are experiencing long-term homelessness, they're oftentimes cycling between these very expensive institutions. And this graph shows you where folks are when they're not in housing and the cost differential of that versus providing Housing First services. And then this next graph here just shows you that information another way. This is a study that we took of 129 individuals that we were serving. We looked at where they were the 6 months prior to entering our program and then where they were the 6 months after. And as you can see, that's a dramatic cost difference on the health system and correctional system and emergency services system for the state of Vermont. And finally, just to wrap up our outcomes, our Housing First demonstration has been widely successful here in this rural environment. We've found that our statistics match up and align with urban settings. One of the biggest, most widely shared statistics about Housing First is that it has an 85% housing retention rate, and that is true in Vermont as well. This means that on any given night, 85% of Housing First participants are in a place of permanent supportive housing. And that's in comparison with only about a 45% housing retention rate for a more traditional approach, which asks that people demonstrate readiness prior to receiving permanent supportive housing. We've seen that almost everyone in our program has either maintained or increased their income throughout their tenure with us, and we've seen a significant reduction in chronic homelessness across the state through the implementation of this program. And finally, I'll just highlight that just relatively recently, in the past couple of years, we've begun billing Medicaid for our Housing First services. So we're really utilizing Housing First as a behavioral health intervention and as a mental health service along with a housing service here in the state. Thanks, Jane.
Okay, Zach, do you want to pick up there?
Sure, and what a great setup by Lindsay. Hi, folks. Glad to be here. Going to talk to you a little bit about how we're utilizing Housing First in West Virginia in terms of the context of our housing, and talk a little bit about our partnerships in terms of housing and healthcare. So Lindsay hit on a little bit of this, and this is kind of what we all deal with in a rural context, is that our rural realities is we travel really long distances to do much of anything, usually over very mountainous and snowy and wood-filled terrain. Deal with what I'll call lazy support agencies. So Lindsay hit on this a little bit. I'll be a little less diplomatic in that, from county to county in West Virginia, we have varying degrees of basically quality and interaction with support services in the form of health care, mental health care, substance use services. Also, Jane hit a little bit on our cultural perception issues. So we deal with things from the standpoint of, people choose to be homeless, who should we be helping versus who we shouldn't. And we deal with a lot of myths in the rural context of, it's for a lot of folks, it's easier to kind of give stuff out to do things that have been proven long-term not to really work. When we, in our context here in providing services in West Virginia, we try to go the other route, more the route of what Lindsay showed with what Pathways has learned. So we put a lot of the good work and historical work that Pathways has done into real pragmatic context in delivering services in West Virginia. So who we are, a little bit about us. We are the State Coalition to End Homelessness in West Virginia. So we do a little bit of everything in terms of advocacy and education, technical assistance throughout the state. We also happen to be the Balance of State Continuum of Care. That's what COC means. So you can Google Continuum of Care, but basically it is a formal body sort of anointed by HUD to carry out various administrative and fiduciary tasks and monitoring of, in our case, about $4 million in HUD Continuum of Care money throughout about 38 projects in West Virginia. Our Balance of State Continuum of Care covers 44 counties in West Virginia. So on the little map of West Virginia, we are you'll see we have 4 continuums of care in West Virginia. We are the big one. There are only 55 counties in West Virginia. We cover 44 of them as a continuum of care. We are also the HMIS, or the Homeless Management Information System, for the Balance of State Continuum of Care in West Virginia. That's our client-level database. That's where we get the majority of our data. We oversee that database and make sure that people get training, and we look at our performance data, et cetera. We are also the SOAR state lead. You can look up SOAR, but it's SSI, SSDI, Outreach, Access, and Recovery. A SAMHSA program that helps to teach a curriculum to case managers to sort of accurately help clientele get on SSI, SSDI the first time around, which becomes very important for our higher need folks in terms of having enough income to stay in housing. And last but not least, and what I'll focus on a little bit, is we are a direct service provider in West Virginia. So in about 22 of our counties, we do what's called Emergency Solutions Grant Rapid Rehousing. We do what's called PAT, street outreach, throughout our 22 counties. So kind of to boil down our beliefs into a nutshell, this is what we believe, that homelessness is very costly, as Lindsay showed earlier. We believe that anybody can be housed, and we put that to great effect on the ground. We do a lot of prioritization. I'll talk a little bit about that, but we think that limited resources must be focused on those who require it the most. So the folks who are the highest need, the most likely to die on the street, unless we have sort of unending resources, people, time, money, which none of us have, I don't think, we focus very much on making sure that housing and services get to the folks who are going to need it the most, who are out on the street. We believe that homelessness is not a punishment, and housing is not a particular reward. And the only solution to homelessness is housing. It's great to have a lot of other stuff. It's certainly not the only thing that helps to keep people in housing, but we got to focus on housing first in everything we do. So a lot of where we come from in terms of our mindset comes from what we call the typology of homelessness. So you can look this up. This has been a wide study that looked at kind of as people enter the system, how do the groups break out in terms of homelessness. So based on a lot of the data that's been culled over the years, we know that about 80% of people are homeless once. They solve their own homelessness and they're never homeless again. About 15% of people need a very short intervention, such as rapid rehousing. And before I go much further and talk about rapid rehousing, when I say that term, I'm basically, for those who aren't kind of in the housing world, rapid rehousing is basically a rental assistance subsidy where we take people either from the street or a shelter, and depending on the type of money we're using for rapid rehousing, we put them directly into an apartment and then start delivering case management services, the leases with the client and the landlord, and we pay the rent, and we provide all the case management and support services. So about 15% of people need that short intervention. And about 5% of people that come through the system need more intensive long-term interventions such as housing first and permanent supportive housing. So our chronically homeless folks are long-term homeless individuals and families. So why is that important? Because we use something called the VI SPDAT. I won't go too much into depth on that, but it's a assessment, a triage tool that we use for everyone that comes into our system throughout our COC. So it doesn't matter if you come to a shelter or if you're found during outreach. We do an initial assessment in our homeless management information system that asks a series of questions across dimensions that gives us a score, that gives us a pretty good guesstimate of most likely where a person probably should fit into our housing profile next. We do a lot of housing-driven outreach. So when we talk about street outreach in a lot of places, sometimes street outreach is kind of predicated or done in a way that we kind of go out, find people, give them stuff, et cetera. But in West Virginia, we do very much a street outreach, going into the woods, underneath the bridges, out in the places where we can find people to offer them housing and to try to navigate their way into housing. We do progressive engagement in our rapid rehousing program, and what I mean by that is we don't sort of do one subsidy or one kind of cookie-cutter program, but we look at what's the amount of subsidy and assistance we can provide that will help these folks, either individuals or families, get back on their feet, stay in housing, so we don't go sort of full tilt and give them the whole enchilada, but neither do we kind of do a cookie-cutter approach. We do housing first. So we put people directly into housing no matter what, no matter their level of income, if they have any income, no matter their level of sobriety, no matter their substance use issues, their mental health issues. We get people into housing first, and then we start to work on the kind of everything else. We use what's called the full SPDAT. If you look up SPDAT, Service Prioritization Decision Assistance Tool for our case management. So it kind of goes hand in hand with the VI SPDAT that we use as the initial assessment, but helps us dig deeper in what are the areas where we need to work on with a client. The full SPDAT, if you look that up, is from Org Code Consulting, really helps us in terms of we travel huge distances across West Virginia. We have a pretty large caseload amongst a very small staff, and we have to make sure that we direct our time and focus it in such a way that we're going to have the biggest impact and keep people in housing. Thought and care in our geographic coverage. So we look at trends across these 22 counties, and we focus our efforts on the places where we're going to be needed most. We don't sort of wander around the frontier aimlessly, if you would. We have to work around broken systems. So we don't wait for things to be fixed in terms of what we can't control out in the system. We can't find good substance use treatment or good mental health care or good health care for somebody, then we find a partner in a neighboring county, or we try to figure out a network or a partnership that's going to help in that particular county. We try things, we fail at them, we reassess what's working, what's not, and we refine what we're doing. So please don't get the impression that anything I'm laying out here is like perfect. It's definitely not perfect, but we're big believers in sort of imperfect implementation over sort of perfect planning all the time. Doesn't mean that we're haphazard, but at the same time, we go and do stuff. We're also big believers in collaboration as much as possible, and we're going to talk a little bit about that today. So rapid rehousing, and I hit on this a little bit, is an intervention that rapidly connects people to housing. It's time limited, so it depends on what kind of subsidy you're using for rapid rehousing. In some cases, it can be a year. Usually it's 24 months, but you've got that much time to focus on getting somebody ready to pay their own rent effectively. For us, it's been a huge boon, and in a lot of rural areas, rapid rehousing has been an excellent program, and that it's pretty flexible in the way that we can house people. In a lot of cases, we have to rehouse people. In a lot of cases, we have to move people from one really super rural area where there aren't many resources at all into a place that has more resources. So that's been really helpful to us. In our case, we have used rapid rehousing for chronically homeless people and high acuity people, and I proceed with caution because I don't want anybody to get the impression that rapid rehousing is sort of meant for chronically homeless people. But in our case, we don't have enough permanent supportive housing, the type of housing that you would use more often for high-need, chronically homeless people. So we will often rapidly rehouse high-need, chronically homeless people because there just is no permanent supportive housing in areas. In some of our counties, we're the only service provider there. There is no shelter. There is no permanent supportive housing. There's no transitional housing. So we do a lot of that kind of walking the thin line of rapidly rehousing really high-need people, and the key to that is really good case management. We connect to housing and services, including moderate to intensive services. Rapid rehousing is not something, again, that can be cookie cutter. It's not something that should require income to access, and it's not something that should lack case management. The only success you're going to have in keeping people in housing is good support services and case management. Another thing that we've done throughout West Virginia, and you can check out that link, or you can Google H2 or H20 Technical Assistance, is we got some HUD and Health and Human Services Technical Assistance in West Virginia to look at bringing the various providers in West Virginia, both in the homelessness and housing side of things and the healthcare and mental health care side of things, to look at how we can more closely collaborate. So this is kind of an ongoing process that we're going through in West Virginia, and certainly not all hashed out, but these are just some basic goals. So a lot of it's focused right now around collecting and organizing and using data across our systems, both in our healthcare and our homelessness systems, to look at who are our most frequent users, how can we target those folks, what is homelessness costing basically the healthcare system, and looking at fostering those ongoing collaborations between our housing providers and our health systems, and so we can integrate a little bit of that care and keep people in housing and keep them healthy. Looking at bigger kind of scope policy issues, transforming our access and delivery of healthcare and housing as an open system, and maximizing the use of Medicaid and our other existing resources so that we can do more housing and keep more people in housing.
That's great. Thanks, Zach. I'm going to pass it on to Terry Kluch.
Good afternoon. This is Terry Kluch. I'm a registered nurse, and I'm the dental administrator for Family Health Center, Marshfield Clinic. This is a federally qualified health center I work for, and we work in collaboration with Marshfield Clinic, which is the largest private group medical practice in Wisconsin. As you can see from the slide, we cover a large geographical area in Wisconsin. It's close to 12,000 square miles of coverage where our dental centers are located. Family Health Center has 10 dental centers in 10 counties. It's mostly rural, central, northern, and western Wisconsin. Our first center was established in Ladysmith in late 2002, and this clinic was a collaborative effort with Family Health Center, the state of Wisconsin, and the Ladysmith community, and then Marshfield Clinic. At that time, Family Health Center contracted with local dentists to assist them in oral care of their patients, but with declining reimbursement, fewer and fewer dentists were able to take patients on medical assistance. We also have seen a great growing shortage of dentists in our rural communities in Wisconsin. Many practices closing their doors, unable to find young dentists coming to northern Wisconsin to take over the practices. Little did we know when we opened the first facility in 2002 that patients would come to us from every county in the state. We soon had a waiting list of over 3,000 people, and it was almost not able to be managed. Dental caries is still the most common chronic condition among our nation's children, 5 times more common than asthma. Our second clinic opened in Chippewa Falls, and we were contacted by that community to help them as a growing number of their patients were traveling to Ladysmith. And then the growth of our program actually took off. So we've been very busy. Our partners, as you can see listed, vary from public health departments. They're often one of the first contacts for us to be engaged in their community, unable to find oral health services for their patients, human services departments, the Veterans Affairs, community hospitals and clinics. We have partnerships not only with Marshfield Clinic, but also with non-related Marshfield Clinic hospitals across northern Wisconsin, who we work with and also provide care within their hospitals for patients with chronic illnesses and a lot of patients with disabilities. We work at the Aging and Disability Resource Centers, child care centers, the Head Start centers that we work with. We are doing telehealth or teledental with them to be seeing their patients, as they could be as far away as an hour or 2 hours from any of our centers. The Chamber of Commerce, adult daycare services, women's health centers. We work at the University Extension offices, the Salvation Army, Red Cross, our school districts, both public and private, universities, our technical schools. Our technical schools have been really important to us because as workforce is one of our major issues in northern Wisconsin, to be able to provide a trained and competent workforce to man all these centers. We have established 2 dental assistant programs working with our technical schools here to train dental assistants, and we still have a shortage of finding staff. We also work with tribal services. We were, for example, invited into Black River Falls by the American Indian tribe there, who asked us to assist them in setting up services for the nation, which covers all the way from North Dakota into the southern part of Wisconsin. Each of these centers has kind of a personal story as to how they were established, and I think we'll get into that a little bit later. It is amazing to consider that in the counties where we have dental centers and the counties around us, 1/3 of all the Medicaid disabled enrollees who managed to receive dental care in the state in 2014 received that care from us. So we give care to about 60% of our patients are on medical assistance, and the remainder being part of a sliding fee program and also private pay. One of the other components of our that I wanted to share with you is called our Community Connection Team. And I know this slide is very busy, but we gathered this data recently and are so excited to present this. Family Health Center of Marshfield, Marshfield Clinic, and the University of Wisconsin-Eau Claire, which is a four-year college, developed a program to engage students and community volunteers to be community health workers. The community health workers are housed within the healthcare setting to connect patients with community resources with the goal of improving health and the quality of life. This program has taken off and started in our medical clinics, and as of this last year, we also adapted it to our dental clinics. As you know, healthcare turns to traditional approaches like medicine, therapy, or procedures for treatment of illness or disease, but patients having unmet needs and social needs, which can have an impact on their ability to address healthcare needs to get well again, is needed. Research shows that 10% of health outcomes are driven by medical care, while the remaining 90% are impacted primarily by the social, behavioral, and environmental factors. And so working with these college students who are housed within our medical and dental clinics, our ability to connect with patients, and as you can see the slide, I think, as you see on there, housing is 24% of the need of the patients that we are seeing, along with dental, clothing, food, and utilities, of course, being the highest. Our staff is trained to work with resources across the area in western Wisconsin to help obtain whatever the patient's needs are, and we're logging this data and reporting on it, and we meet monthly to discuss the needs and how we're going to develop this program further, and then into which communities we're going to take it. And I think I will include some of the questions later for discussion. Thank you.
Yes, that's right. Thanks, Terry. I think that's, for all of you to know, I first heard about Terry's, the program, the dental, as I was listening to NPR a couple of weeks ago and how they were serving, providing what we understand are very needed services throughout Wisconsin. So we're going to now switch to the dialogue. And so let me start the conversation with all of our panelists with who are the frequent users in your community and what are the systems that are they interacting with? And also maybe you can touch on if you are impacted by the drug epidemics that we're hearing more and more about that are impacting rural communities. I'm going to start with you, Lindsay, because I know you had sent in a couple of slides about John in sort of representative of who you're serving, and then we'll switch to the other panelists as well.
Sure. Yeah. So I've had the great just honor of being able to, having permission to share John's story. John is somebody who was referred to us the day after his 69th birthday, and at that point he had been homeless for nearly half of his life, so several decades of homelessness. John was a self-proclaimed alcoholic and had been in and out of a number of different treatment facilities in his adult life. He had had 12 inpatient psychiatric hospitalizations. He was often picked up by the police for trespassing in areas where he was trying to find a place to sleep, thrown in the drunk tank for the night. And he had a number of very pressing medical issues that weren't able to be well addressed while he was experiencing homelessness. And these factors, combined with John's advanced age, put him at imminent risk of death on the streets. As Zach mentioned, the VI SPDAT is a tool that we also use for determining someone's vulnerability, and John was high on that list. I guess just to give you a little bit more about John was somebody who oftentimes slept outside. Encampments is a relatively big thing for us in the state of Vermont, and he was often at encampments. He would sometimes access our shelter system. Our shelter system most often require that folks be sober in order to access them. And so this is something that often wasn't available to John when he was drinking. He's relatively representative of somebody that we might find and encounter and work with. And I guess just this slide here on this screen here shows that so John was somebody who really benefited from a housing first approach. We were able to quickly put him into housing, and from that point he was able to address some of these more pressing needs. He got connected with a primary care physician for the first time in decades, and he was able to have a shoulder surgery. He had a shoulder that kind of perpetually dislocated, and he was finally able to have surgery on it once he had a stable house that he could return to for follow-up care. John did pass away just a little over a year ago from cancer, but at that point he had been housed in our program for over 3 years. And we truly believe that that's 3 years that were a gift that we got to have with him. He's a really amazing person. So that's John.
So Zach, you already talked about some of the conditions and factors that you find in your communities. How do these factors impact access to care for the constituents?
In several ways, and this is where we run into, at least in our state. I spoke a little bit to the kind of the uneven quality of services and degree of interaction between clientele, particularly in really, really rural areas. So kind of what we've had to do instead of, and this is how we do most things, by the way, instead of sort of attacking it from the system-wide perspective and trying to make sort of giant changes, we've had very developed very targeted collaborations with specific healthcare providers to start to sort of prime the pump, if you will, or make the case of how this can be sort of an excellent collaboration when we start to look at things like a little bit kind of like what Vermont has done, although we're on the very front end of looking at data in a very specific way, looking at healthcare data as it interacts with our data on homelessness, kind of looking at HMIS, our client-level database, as compared to Medicaid data, hospital data, things like that. On the other end, we've done some very kind of boots-on-the-ground collaboration, and I'll talk about that a little bit later, with one of our federally qualified health centers in literally doing outreach and street outreach and housing and sort of healthcare and mental health care navigation for sort of a smaller universe of people that we're putting in housing. And then we're also going to, after the fact, be looking at that data and how well we're doing with stabilizing those issues. So.
Thanks. Terry, anything else? I know you gave a pretty good synopsis of, what you were finding in terms of the dental care needs in the community. Anything else you want to add in this context?
The only thing to add is that we get numerous referrals from all the medical partners who send their patients to us because they don't have access because of, again, low income or uninsured. So we work closely with a lot of the medical clinics.
I actually saw in one of the questions that has come in, and maybe I'll preempt that a little bit. It was on your long list. Do you have you built relationships with the, as Zach referred to, the continuum of care and the homeless service providers in Wisconsin?
Actually, through the community connections, we started building, asking and working with them as a resource in the Eau Claire area.
Great. Okay. Well, good. We'll learn more as time goes on with that. Okay, let me turn to the next question. So how do you bring the partners to the table? And maybe give us some examples, but also maybe what were some of the difficult ones, and how did you finally persuade them? So Terry, let's start with you. You had a long list of partners there. How did you bring them to the table?
Well, when each community is different how the partners come to the table. We usually have a champion in the community that we work with who invites us to come to their institution, and then we invite several of the agencies within that community. I think the most important thing that we've learned over time is to not tell so much who we are and what we can do for you, but what is it that we can, what is it that we can do for you, not what we can do for you. They tell us of needs they have and transportation needs, and so we get into this a large listing, and we have a template when we go to the community meetings of how we work through the community issues, and it's kind of an open forum, very informal, usually lasts about 2 hours. I would say that, we're trying to ask them to connect with all their clients and people, families and friends who are in need of oral health care, and then to timely get them appointed. One of the most difficult groups we've been able to connect with has been our veterans, and we've offered to attend the veteran functions. We are putting some ads in the newspapers for them. We have found that the veterans to be a very proud group, and I talked to a couple that didn't think they should take these services, but they served our country, and we want to provide care for them and their families. And we're starting to make some inroads with them in 2 of our communities and engaging with them, informing them of our sliding fee programs and et cetera.
That's great. What about Zach? You hinted a little bit about some of the collaborations you've been working on data and working with the university and the health center. So why don't you talk a little bit more about that?
Okay, I can talk about that a little more in specifics. So we have a pretty good collaboration with West Virginia University, and that's sort of hinged around one person, a guy named Dr. David Parker. And Dr. Parker originally came from South Carolina. He was at the University of South Carolina, where a long time ago, they were kind of on the forefront to some degree of doing some of these things we're talking about, where they looked at the cost of healthcare to the health system there, and their university there actually built permanent supportive housing back in the day to deal with kind of the influx of this frequent user, high need cost issue. So when Dr. Parker came to West Virginia, we lucked out. He sought us out because we'd try to sort of get access to the university and to their healthcare system because they're the largest healthcare education entity in our state. So we worked initially on our preliminary 3-year data study looking at HMIS data, which is our homeless management information system, state Medicaid, and state hospital data. We also try to get our Department of Education data and our corrections data, but that proved a little more difficult, which I can get into the weeds on later. But we looked at covered cost occurrences, high utilizers on that data study, and that's still kind of going forward. So we set up the template for that data study. We've pulled some initial data, cost data that I'll go over here in a second, and then we're looking at how we can kind of mine through that. If anybody knows anything about sort of large pots of data, once you have it, you can kind of drill down in and get the kind of stuff that you want out of it, and what you want out of it may change over time. But we've also partnered with WVU on, they'll be sort of integral to our centralized intake throughout our COC in the coming months, and a little bit on the COBI grant, which is a SAMHSA grant that kind of is going to help support what we're doing with housing stabilization and case management to kind of add to the pot. WVU is also a direct service provider, oddly enough. They do HOPA, which is Housing Opportunities for Persons with AIDS in West Virginia. They do permanent supportive housing, and they do a little bit of rapid rehousing. And I co-chair our data work group for our State Interagency Council on homelessness with David. So we've done a good bit up to this point, and now we're kind of refining what we're doing in terms of our partnership with West Virginia University, mostly to kind of make a case of what homelessness is going to cost, or is costing the Medicaid and the hospital system.
Why don't you jump to talking about your partnership with the community health center as well?
Okay, I can, and this is sort of a smaller universe of clientele and a kind of a smaller collaboration, but something that's kind of growing and leaps and bounds over the past year. So Eric Police is an administrator at what's called the Mon Valley Association of Health Centers, MVA, and they're in Fairmont, West Virginia, about 10 miles down the road from where I am right now. But they are a federally qualified health center, and back about a year ago, MVA got some HRSA, Healthcare for the Homeless dollars. They never had that money before, and Eric came to me and said, hey, what could I do with this? So he and I talked a little bit about what would be kind of the most impactful thing given where we were at the moment. We'd already started delivering, of course, direct service in his area by then with rapid rehousing and street outreach, so I floated the idea of, well, with your HRSA dollars, can we look at adding another person? Because really what we need is another person that can be sort of an outreach person, help as a backup case manager, and then provide some direct navigation for healthcare needs for those folks that were housing pretty quickly. And he said, yeah, let's go ahead and do that. So we do have that, and a gentleman named Michael White, and he works in tandem with our staff in the counties that MVA covers to as we house people, he will help with the housing. We can lend out our subsidy money to him, and then they can provide either kind of the connection to the care that's inherent in MVA through the federally qualified health center, or based upon the client's choice, kind of navigate into care in hospitals or detox beds or mental health care, et cetera. So we've done kind of a very small group of folks, about up to 10 clients right now, but that's growing. Actually, we partnered on 2 or 3 additional clients this week, so that's kind of ramping up. But that's been an interesting collaboration and actually doing stuff on the ground with clientele, really integrating housing and healthcare kind of person by person.
That's great. I'm going to pass it to Emma to continue some of the conversation on, and actually we're focused on technology next.
Yeah, and I saw this was one of the questions in the chat box, so we're all on the same page, which is great. So staying connected to your constituents is essential and can be particularly challenging in a rural environment. So we want to talk about how technology is used in your programs and how it's kind of changed the way services are provided in rural areas. and we want to talk about how technology has advanced access and how you're using it and what barriers still remain. So, Lindsay, I wanted to start with you. I believe that technology was integral to the way that the Pathways program was set up in Vermont initially, and I was hoping you could talk about that.
Yeah, that's correct. So I'll put a plug-in for Google Apps, which we've used extensively as the very basis of a lot of our communication, both internal and with folks that are in this program. So what that looks like in practice is first that all of our team members are equipped with mobile technology, including a smartphone and laptop. And that is very important for people who, as we've all mentioned, spend a lot of their days in the field doing a lot of drive time. We're connected to each other via shared calendars, texting, other methods like that. And then maybe even more interestingly, though, and excitingly, we have done a pilot project by which we've been able to offer that same technology, computers, headset, internet, et cetera, to participants in the program as a way to supplement our in-person visits. We've trained people who, maybe otherwise would have been on that digital divide of not being able to afford this expensive technology, but we've trained folks in being able to connect with us via email and Google Hangout, and that's a way to supplement visits so that we can remain connected even when we can't always be directly in person. We've used that both with our team members and also with telemedicine, so folks can connect with our psychiatry and nursing staff virtually, either from one of our local offices or from the privacy of their own home.
I'm curious what feedback you've gotten from participants of what it's meant for them to have access to this technology.
Universally, I think people have been so grateful for the availability of it and for being able to utilize it. I, can think of one person in particularly who had literally never used a computer before, and it was very unfamiliar to him. He's an older person, but he was able to get comfortable with our computer literacy specialist, just doing a couple of kind of trainings with him, and it's now something that he utilizes frequently. And I think particularly for people to just feel that they have that kind of ongoing way to be connected, even if they are somebody who, we might have to travel 30, 40 minutes, an hour to go see, to know that they can reach us at like the touch of a fingertip is really important.
And Terry, you also mentioned telehealth in your organization. Can you speak briefly about how you use that for your services?
Yes, in most of our areas, we have hygienists who connect with the Head Start programs, and they go with their camera and video equipment to a Head Start program. They see anywhere from 20 to 40 children, and that information is relayed back to one of our dental sites where the dentist is sitting. He can view the screens, and we can then schedule the patients the children as needed for care. One of the other opportunities we're looking at is treatment planning of patients takes considerable time for your patients to travel to a facility and then to come back for care. So is there opportunity to go to assisted living facilities, nursing homes with the teledental equipment, and through that be able to obtain part of a treatment plan that when the patient does travel 1 to 2 hours that we could start giving care more immediate for them.
Great. All right, now we want to move on to talking about some of the resources that you all have been able to tap into for both outreach and for services. And so by resources, we're talking about both financial and community assets as well. So we want to start with Terry. The Marshfield Clinic has significantly expanded your dental care across Wisconsin. I'm curious, how are you funding these services, and what can others learn from your strategies? And I also see a note in the chat box that one of the participants is asking about how you pay for the telehealth technology. So if you could also touch on that, that would be great.
Okay, our services are funded through working with the state of Wisconsin with our medical assistance program, federal and state grants and funding we get, some private pay. We've actually had some patients make some private donations to us. We have partners in the community who help fund like an angel fund for transportation or for patients in need in their community who need certain services or dental implants or et cetera that would be needed, that would be special to them. These, they're set up just for those centers. So it's a variety of ways that the funding occurs. I think most importantly is to, you know, as you engage all the partners in your community to discuss that up front and how people can contribute to that. I think it's been just a whirlwind of activity and engaging these services and these partners. So.
Great. And Lindsay, you mentioned at the beginning of the webinar that Pathways Vermont bills Medicaid for your services, and I was wondering if you could talk a little bit about that, as well as on the technology piece and how you've been able to pay for that.
Sure. So Pathways started as a demonstration project, and we were grant funded under a 5-year SAMHSA grant. And as we came to the close of that grant, we were faced with how are we going to ongoingly sustain ourselves after 5 years of research, which shows that this really was an effective approach that was working in this rural state. And that led us into this conversation with the Department of Mental Health, wherein we have now been able to access Medicaid dollars through the Department of Mental Health to bill for the services that we're providing. This is actually the first time that a new agency has been entered into the formalized system of mental health care in the state of Vermont. It's previously been a closed designated agency system. So it's something that we're really excited about on a number of levels. What that looks like in practice is that for most folks that we're providing services to, we're billing fee for service, so we're billing per interaction, and we're billing it as community support services, so as mental health services, which of course makes a lot of sense because the bulk of the work that the team does is in providing ongoing support and stabilization in the community around mental health and other life goal needs. So that's been a really exciting road. That's a very, very condensed version, and I hope is relatively clear, but something that I'm certainly happy to talk with others more about. And then just to very briefly answer your question about the telehealth program, we don't have a formalized system for that. We have had just some pilot grant funds to implement a small project. It's something that we'd certainly like to expand our resources to do more of in the future, to continue to connect folks with technology.
Great. Thanks, Lindsay. And then, Zach, in our conversation, you mentioned various resources. And so we're curious, how did you get started, and what have you been able to leverage in the way of resources?
So how we got started was basically we went after initially and there was our state behavioral health entity, which most of our SAMHSA grants flow through, put some money behind, extra money behind our PATH program in West Virginia. We don't have a lot of PATH money, but it's street outreach money that comes from SAMHSA. PATH stands for Projects for Assistance in Transition from Homelessness. So initially, we applied for that outreach money. Ended up getting it, but one of the caveats that I had, having come from a direct service background, is that we had to have some kind of housing subsidy to go along with that. But what I didn't want to do is go out into kind of the rural areas and then have nowhere to go for someone. I want to be able to house people when we needed to house them. So we went after initially one type of HUD, emergency solutions grant, rapid rehousing money that provided our subsidy. Recently, we've also received some continuum of care rapid rehousing, so a couple different kinds of rapid rehousing money that we can pair with our outreach money and supplies, both people to do the work and subsidy money. In the last year or so, We also partnered across the continuums of care in West Virginia through our state behavioral health entity at our Department of Health and Human Resources to go after yet another SAMHSA grant called CABI, and that's C-A-B-H-I, and that's Cooperative Agreements to Benefit Homeless Individuals. And all 4 COCs, continuums of care in West Virginia, got some money. We were awarded the grant. And basically that's money that's going to provide, at least for our continuum of care, additional support and both coordinating what we're doing across case management, housing, and healthcare, as well as providing at least 2 additional people to do kind of more intensive case management so we can keep people in housing. So on one end, it's all well and good to do sort of volume work and housing a lot of people, but if they're not going to stay in housing, there's kind of no point to that. So what's been sort of the real success for us is both in partnering with our health entities to provide kind of a navigated, streamlined system into healthcare and mental health care, as well as substance use treatment. On the other side of that, real intensive case management once people are in housing to keep them in that housing. So, and we're also looking at other possibilities, like we're really, the more we have kind of outcomes data and are refining that, looking at some interest from a couple private entities who want to provide potentially provide some private flexible money.
Okay, Kim, maybe you can pick up. We've covered some of the questions from the chat box, but maybe there are a few others there. I think we're sort of bordering on getting towards our, I
was just kind of going through them. I think we have a few good ones. We did somebody asked about how folks are using technology to connect healthcare providers and social service providers. Pretty sure we covered that, but I do want to get to one specific question by the same person, actually. How do you find and fund treatment programs for helping homeless with addictions, particularly alcohol and opioid heroin addiction? And I would just add to that, not only find and fund, but access. Is there any of the panelists that want to pick that one up?
This is Zach. I could hit on that one, at least from the standpoint of what we do here. We have kind of a new hotline in West Virginia that our Bureau for Behavioral Health and Health Facilities started up that has been pretty fundamental for our direct service staff and a lot of other folks, a lot of other agencies, in that we can call that hotline and sort of get direct connection based on the geography to whatever's in that area. Now, that doesn't mitigate the challenge of is there an open bed, things like that, but it's been pretty useful and helpful to us up to this point. But it still is a challenge just because of the need outweighs the supply of recovery services here.
And this is Lindsay chiming in too. I'll just say that Vermont has definitely been hit by the opioid epidemic. And we've seen a stat number of people pass away from overdose. We have made a lot of efforts to increase access to Suboxone and methadone maintenance hubs throughout our state by placing them directly into rural communities. And that's made some difference in terms of people being able to access that as an additional resource. We also just recently implemented a task force of community stakeholders around the opioid epidemic to help increase access to resources for folks that are struggling with that.
Thank you. We had another question come in that I believe was for Terry specifically. And the question was, how can supportive housing providers or other service providers in the continuum of care link clients to dental clinics? Where do we find them?
Could you repeat that, please?
Sure. Do you have any advice for how supportive housing providers or other homeless service providers can link clients and help them access dental care? Dental clinics, I'm sorry. I had to scroll back up.
The most effective way I would see not knowing where they are across the system would be the community health centers who have dental clinics, take underserved patients, and again, it would depend on the area.
Okay, thank you. Here's a question that I think particularly Lindsay might be able to answer, as well as Zach. The question comes from somebody in Missoula, Montana, and they're asking, what kinds of housing are organizations using for Housing First? Do you have your own facilities, or are you working with local landlords? In their area, Missoula, they have a serious housing shortage, and it's hard to imagine how to implement a Housing First initiative.
So this is Lindsay. Yeah, we are utilizing a scatter site model. So that means that we are working with private landlords to provide housing. Part of the model is that Pathways doesn't own any buildings, and we don't have any buildings that have staff on site. So folks are, integrated into the community in that way, leasing up private independent apartments. Availability of affordable housing is certainly an incredible issue here. Our vacancy rate statewide is under 1%, and then the pool of affordable units is even smaller. One strategy that we've utilized with a great success is that we have a separate housing team who acts as a property management team, and their main role is to recruit landlords and units, and then to support the health and wellness of the unit by ensuring it passes inspector and rent gets paid on time, things like that. And that's been a great asset for us because, the biggest thing is that landlords are renting in the community anyway, and being a landlord has its set of risks. So by being able to provide as a resource a dedicated team who's going to be there with the landlord, we can assure the landlord that there's someone there if issues do come up or the risky situations do happen.
Yeah, and perfect ditto on everything that Lindsay said for us. We do scattered site only. We do have some site-based permanent supportive housing with other agencies, but scattered site is much, much better in terms of outcomes for people staying long-term in housing. We also have a housing shortage, an affordable housing shortage. We're just very intentional and aggressive about going out and making the case to landlords and cultivating landlords and explaining that we're, a good business deal for them, and then housing people in a scattered site fashion out in communities.
Thanks, Lindsay and Zach. So I'm going to go ahead. I don't see any more questions, and I'm going to go ahead and advance to the next slide here. Hopefully Jane can do that for me. But thank you everyone for attending our webinar today on helping improve care for frequent users in rural settings. And thank you also to our three presenters from Vermont, West Virginia, and Wisconsin. Terry, Lindsay, and Zach, really appreciate your perspectives today. The recording of this webinar and our slide deck will be sent to all attendees as soon as they're available, and there'll be a link to the recording in that email. Our next webinar will be in exact date to be determined in November this year, and it will be on finding capital to expand health center capacity, particularly when that's involved with supportive housing. When you log out of today's event, we hope that you all pay attention to a pop-up window that will appear displaying a survey about this webinar. We really value your input, and it matters for us when we're reporting to HRSA about the kinds of trainings we're doing and the kind of trainings we want to do. And we also hope that you'll visit CSH's HRSA TA website, csh.org/HRSA TA. Finally, this webinar is funded by our HRSA National Cooperative Agreement, which is funded national organizations that receive HRSA funds to help health centers and lookalikes meet program requirements and improve performance. They also support health center program development and conduct national analyses around the target audiences of vulnerable populations and underserved communities in the country, including the homeless. So thank you once again, and I hope you have a great week and weekend.